Good afternoon, everyone. Welcome to the webinar of the Geriatric Emergency Department Collaborative. My name's Don Milady. I'm an emergency physician at Mount Sinai in Toronto in Canada, and I'm a faculty member with the Geriatric ED Collaborative. Today, we're continuing our series of webinars that focus on the COVID-19 pandemic and its impact on providing care to older people in emergency departments. Today's webinar is about telehealth and how it can be used. So both in general, but particularly during this time of COVID. We've got a diverse audience on the webinar today: clinicians, administrators, managers of healthcare systems across the United States and from around the world. And we've got 4 excellent panelists. The Geriatric Emergency Department Collaborative, if you're not familiar with it, we're a network of community and academic emergency departments. We're working together to define and set out best practices in geriatric emergency department care. We provide education to clinicians about models of care that improve care for older people. We support emergency departments and healthcare systems to implement models of care, and we conduct research and evaluate outcomes. So if you share the vision that we have, you can see on your computer screen, we'd be very pleased to have you as a member of our group. Membership is currently free. You can check us out on gedcollaborative.com, and you can follow us on Twitter. The Geriatric Emergency Department is generously supported by the John A. Hartford Foundation and the West Health Institute. We really appreciate the support they provide us, which allows us to continue this work. So before I introduce our panelists, I want to just make sure that everybody is familiar with Zoom webinar. It's a little bit different from Zoom meeting. So all of your microphones have been muted. Nonetheless, we do want to hear from you and we want you to participate. The best way to do that is through chat. The question and answer function has been disabled and we won't be using it, but you can access chat by hovering your mouse over your screen. See chat at the bottom of the screen. I'd encourage you to keep it open through the whole webinar because there's a lot of interesting stuff happens in there. I would ask you right now to make a change. If you have opened the chat box, it probably says that the messages go to panelists. Please change that to all panelists and attendees so that everybody can share in your observations, questions, and wisdom. So as we get started, can I ask everybody who is on the webinar to text into the chat box where you're calling in from, what your role is, and if you have any particular questions that you want answered, topics you want considered. Please put that in. Also, as we're going on through the webinar, and if you have resources or links or good ideas, please include them. The chat box will be available to everyone after the webinar is over, so it's a good way to curate all of those things. The webinar is being recorded. It will be up on the gedcollaborative.com website probably early tomorrow. And you can check in there for the slides, the chat, and the webinar itself. So as I said, today's topic is ED-based models of care for telehealth for older adults. We've appended in the age of COVID-19. I think most of what we're talking about applies all the time as well. This webinar here develops themes that are presented in an article. Next slide, please. An article that appears in the Journal of Geriatric Emergency Medicine, which is hosted on our website. Most of the authors of this article are on the call today, on the webinar today, so you'll have a chance to hear it directly from their mouths. And as I said, it's available as of tomorrow. I'm going to take a moment to introduce our presenters before opening the discussion. Next slide. Kevin Biese is the Academic Vice Chair of Emergency Medicine at the University of North Carolina, and he is the co-principal investigator of the Geriatric Emergency Department. Jeff Davis is the Director of Regulatory Affairs at the American College of Emergency Physicians. Mike Kurlian is the Director of Telehealth and Process Improvement at West Health in San Diego. And Kevin Curtis is the Medical Director of Telehealth for the Dartmouth Hitchcock Health System and an Associate Professor of Medicine at Dartmouth. So I'm going to ask Kevin to lead us off. Kevin, I know you've been involved with telehealth for a long time in many different ways. Can you just describe what you mean when you hear the word telehealth? What do you think it means? And specifically, how is it relevant to the emergency department and the care of older people in emergency departments?
Don, thanks so much for having me on today. And and Kevin and Mike and Jeffrey, thank you so much for joining in. If you would have asked me that question a month ago, I would have said, telehealth is about the very simple concept of bringing the expertise to the patient instead of the patient to the expertise, about limiting some of the iatrogenic forces within healthcare, increasing the value and trying to just improve care by getting information out the way we get the rest of the information out. I've said for 5-7 years that in a world where my mother can read to her grandchildren on FaceTime bedtime stories from 7 states away, I have no idea why people are driving 4 hours to talk to their cholesterol doctor about their LDL numbers in person. It just didn't make any sense. But in the last 2 months, that answer to that question for me has changed. And when you ask me what telehealth means today, it means safe healthcare, right? I'm terrified of a concept called excess deaths. COVID is real and COVID is killing people. There's no doubt about it. But there's a concept called excess deaths. Excess deaths is, let's say that, I don't know, that like Auburn was at war with Alabama and they're pelting each other with footballs and knocking each other over. And then they tally up the deaths and they say we've had 50 deaths on the Auburn side, but only 30 of them are from footballs. What happened to the other 20 people? When we look at COVID right now, there's some terrifying data out there that excess deaths are happening right now in our society. Deaths are up in New York State, or actually New York City, by 225% compared to this time last year. In New Jersey by 72%, Michigan substantially as well. But the thing is, only up to 50% of those are accountable from COVID. A whole lot of those deaths are from non-COVID things. And I think it's becoming clearer and clearer that people are scared to get healthcare today. So for 5 years, the answer to that question has been efficiency, people not having to drive across the state, park their cars, do all this stuff to see a specialist. But today it's all those things, and it's also about safety. We have got to find a way for people to feel comfortable getting the health care they need so that they don't die at home from heart attacks. In Northern Italy, when COVID hit bad, during a 20-day period, the out-of-hospital mortality rate went up 58% compared to the year before. We've got to find a way to get people safe healthcare, and that's what telehealth means to me today.
Thanks a lot. So I think some people might be having some trouble wondering how telehealth specifically relates to emergency departments. And what do you think about that?
No, absolutely. So emergency departments, right? Emergency departments are staffed by people that are experts in acute unscheduled care. And we should not be defining, my job is not defined by where I work. It's the expertise that I bring to where I work. So emergency medicine is the essence of being able to provide this acute unscheduled care to people wherever is most appropriate for them to get that care. Sometimes that's within the emergency department. Sometimes that's in a skilled nursing facility. Sometimes that's from one emergency department to another where resources are concentrated in one and transferred to the other. So emergency care has got to be how we beam out this expertise and help people get care at home or make sure they get care in the right place at the right time. And if we can provide that reassurance, they'll be a lot less scared to reach out to us and able to join with us. One other thing I'd love to mention, Don. this little tidbit about, by the way, now we get paid for it. CMS has done some remarkable transformation over the last 6 weeks as far as waivers. And at least for the time being, we get paid for it. And I'm so glad Jeff's on the line. He'll explain that in a lot better detail. But we have to provide safe care, and we can do it in a sustainable way right now. And so I'm thrilled that you and Kevin and Jeff and Michael are on this webinar, because we want to do everything we can to get this information out to hospitals across the country so that we can share our expertise with people that might be too scared to get it right now.
Thanks for that, for addressing the question and the wonderful segue to Jeff, who may be one of the most important people on the panel today, because while healthcare is all about providing care to the patient, it also only happens if there's some money flowing. And I think that many of us are still lost in the old days, 8 weeks ago, when telehealth just wasn't a kind of financially possible, feasible thing. So Jeff is the go-to guy at ACEP, the American College of Emergency Physicians, around regulatory affairs. I'll direct you to his blog shortly, but he knows everything there is to know about funding and reimbursement. So Jeff, I'm turning it over to you. Can you just walk us through some of the big financial and reimbursement changes that have happened over the last few weeks?
Sure, I'll be happy to, and thank you so much for including me today. I'm going to be talking about Medicare policy changes, and again, this doesn't affect all patients. State Medicaid programs and commercial payers could have separate policies, but Medicare and CMS, like Kevin was saying, has made tremendous strides over the last few weeks in terms of expanding flexibilities under Medicare. Next slide, please. So traditionally under Medicare, they have very restrictive requirements. I'm sure you're familiar with this in terms of telehealth. They restrict where you can provide services and what geographic locations, only in rural areas. CMS has totally broadened those restrictions so that telehealth services can now be provided from any location, including both urban and rural locations, and no matter where the provider is and no matter where the patient is. The Department of Health and Human Services has also issued a HIPAA waiver for the use of everyday communications technologies like FaceTime and Skype. Also, telehealth is usually defined as having video capabilities. For the time being, CMS has also allowed telephone or audio-only codes to be billed at the same rate as office and outpatient evaluation and management services. In terms of emergency medicine, going off of what Kevin said previously, they have really expanded the use of telehealth in emergency medicine. And I would say this is our opportunity to show the value of emergency medicine telehealth. You can now provide a medical screening exam via telehealth. And this is something that we were pushing for at ACEP at the very beginning of the pandemic in order to protect our providers and preserve PPE. In addition, they've added the ED, the Emergency Department Evaluation Management Codes, the Critical Care Codes, Observation Codes, all temporarily to the list of approved telehealth services. And like Kevin said, these services are paid the same rate as in-person services. Next, they said how you're supposed to bill for telehealth services. The place of service code should be the same as if the services were provided in person. All you have to do is add a modifier of 95 if the provider and patient are in separate locations. And finally, the HHS has issued a waiver to allow physicians who are licensed in one state to provide services to patients in another state. Next slide, please. So there are 4 points I want you to remember from all this. Anywhere. Telehealth services can be delivered regardless of where the patient is or the provider is. Number 2, equal payment. Telehealth services are paid the same rate as in-person services. And then coding. You should use the same place of service code as if the service were delivered in person. So for the ED, if you're delivering evaluation and management codes, please use place of service code 23. Also attach modifier 95 to that claim. Finally, these changes are temporary. They only last for the duration of the pandemic. They're not for now long-term changes, but I can describe more about that in a minute as well. And then, as Don was alluding to, this is my Regs and Eggs blog. I write a breakfast blog every Thursday morning. While you're eating your breakfast, you can enjoy some Regs with your eggs. I write on topics of all regulations impacting emergency medicine. Most recently, I've been talking a lot about telehealth and all other issues related to the COVID-19 pandemic. And we're also at ACEP updating our website very regularly with all the different guidance that CMS and other federal agencies are putting out. The guidance is flowing out like wild. Every day there are new changes. So we're constantly updating our website with the most recent guidance and regulations. And we can send you that information after the webinar as well.
So all of those, thanks, Jeff. All of those links are live. You'll be able to access them directly from the webinar recording. So Jeff, your last word on your last slide was temporary.
Yes.
So is the world all going to change back once COVID is over, whenever that may be? And as a guy who writes a blog on regulations, it seems to me like you're the right person to ask for some opinion, at least, about how things are going to change over the months to come.
Yeah. I think we have let, as the administrator of CMS, Seema Verma, said, we have let the genie out of the box, and there really isn't any going back to where we were. That being said, Medicare does have very restrictive policies in terms of telehealth, which need to be changed by Congress in law. So we can't continue doing what we're doing completely with all the flexibilities after the pandemic ends. Congress will need to take action, and there's actually probably some movement in Congress, hopefully, to do that and make some long-term changes to telehealth. But again, we probably would not go back to where we were before, because we're really seeing the value of telehealth, especially emergency medicine. I also want to note that ACEP has pushed for years to get the ED/E&M codes, the Emergency Department Evaluation and Management codes, permanently added to that list of approved telehealth services that Medicare can bill for. So that's a permanent change that we've been pushing CMS to do. And they made it temporarily for now, and hopefully, because of the value of emergency medicine and telehealth, can get them to permanently add those codes to the list of approved telehealth services. So that's something we'll look for in the future. But again, Congress will need to step in to allow all the flexibilities that are currently approved under this pandemic to be permanent.
Thanks. So it's been an interesting theme over these last few webinars, which have all been on the theme or a topic of COVID-related care. But the theme is that this era may be bringing significant changes, many of them quite good, that are going to be enduring after the fact. So, on our palliative care topic, we're talking about that palliative care is now much more accessible in emergency departments. On our transitions of care between long-term care and emergency departments, places all over the world are finding new ways to communicate better. So this may be another area. There are a couple of interesting questions in the chat box, which you're probably the best person to address them to. John Schumacher asked, do these payments apply to non-Medicare plans? And would they apply to younger patients and other health plans?
So yes, so the changes I'm talking about are for Medicare. But if we look at states, state Medicaid programs and commercial payers, they are doing a lot in expanding telehealth. Now, each state and each commercial payer varies in terms of what they are doing. Some of them, for instance, are some commercial payers are allowing reimbursement for evaluation and management services, but only for office and outpatient settings, and not specifically for the emergency department evaluation and management codes. Some are including those codes. Some states are doing the same thing. They're expanding telehealth, but not including the ED/E&M codes. So it varies across state and across commercial payer, but Medicare is definitely setting the lead here in terms of being very, very aggressive in terms of the flexibilities they're setting. But that does raise an interesting point about different rules depending on different payers. You could have different rules for your Medicare payers in terms of telehealth, and then for commercial payers, and then for your Medicaid patients. I think the best way forward would have to have all these payers and all these rules be aligned, but that's definitely tougher said, easier said than done. So that's the ultimate goal, but I think Medicare is definitely leading the way in this.
Yeah, thanks. And on this topic of easier said than done, Chris Carpenter has a question in there too, which I think is foremost in many people's minds. What about privacy? And the question specifically is, what do you recommend what message to send to our institutions who are really afraid of HIPAA violations, using commercially available online things like Zoom and FaceTime. In the old days, 8 weeks ago, that really was not permissible.
Yes.
How do we communicate that things have changed to our institutions?
Yes, I mean, and again, these are temporary waivers, and the Department of Health and Human Services has, like I said, waived HIPAA for FaceTime and Skype. But I think that we really need to use these services appropriately, and institution by institution set up protocols and security and privacy protocols to make sure that our patients and providers are protected. But I think CMS and HHS, they have gone a long, long way in terms of providing flexibilities. And there could be some might argue, some implications of how broad and how flexible they're being. But I would say institution by institution, you should be setting up your Zooms, your FaceTimes, your Skypes in a way that protects your patients and protects your provider security. But that's really going to be up to the individual institution, I would say.
Either now or more likely later, Kevin Curtis, when you're talking, I think, and many of us would be interested about how some of these privacy concerns have been addressed in your site. But let me move on. Thanks a lot, Jeff, for the nuts and bolts of and following the money. I'd like to move on to Mike Kurlian from West Health. You've been doing a lot of work, Mike, around a very specific project, and that is linking emergency department to post-acute and long-term care, what people might call nursing homes in the San Diego area. Can you just tell us about that program and what you've learned from it? Is it possible Mike, you're on mute? We don't want to lose anything that you've got to say. There.
Yes. Well, thank you, Don. Pleasure to be on the panel, speaking with you and the GED audience. When I look back, in order to make anything work with these facilities, we had to first better understand them. We found out, and what we found out shouldn't have been a surprise, but it was to me. Before coming to West Health, for instance, my telehealth career was spent in pediatrics. And although the elderly and the young can both be considered vulnerable populations, I had no idea of what the challenges were. For instance, long-term care facilities are being asked to take care of a growing medically complex population that is living longer and will at least double by 2030. Compounded by the facts of the decreasing pool of available clinicians, particularly PCPs, specialists, and depending upon what state you're in, a decreasing amount of RNs. We know these things are already straining our healthcare system, because if you tried to see a specialist before COVID-19, you may have been waiting weeks, if not months, for your appointment, depending on the specialist. The fact that there's a GEDC also highlights that healthcare organizations were already experiencing the increased needs of a geriatric population. What we also learned was that long-term care communities rarely used or even knew about the different ways telehealth could be used. And still, even today in the world of COVID-19, I wouldn't assume that they all do now. Once we had a better understanding of LTCs, we were able to better identify their needs, highlighting that understanding their needs was key, which allowed us to identify what problems they had and which ones were appropriately addressed by telehealth. And what kept coming up, and extremely relevant to this audience, was the need to manage acute, unscheduled care and avoid unnecessary utilization of hospital, ED, and transport resources.
So,
next slide, please. Oh.
Yeah, go ahead to the next slide. So I
Well,
think, what were some of the things that you learned?
Well, since March, long-term care organizations have been contacting me from all over the country with a message I wasn't used to getting, and you know, still sometimes it surprises me, and I don't know why. The messages sound like, we want telemedicine and we want it now. Mike, what's the fastest way to get us up and running? And we'll figure out the details and how to make it better along the way. Let's just get this thing in and go. These are completely different messages than what I was used to getting. I was used to, with the pat on the back, this is very interesting. I think it's the way of the future. We'll think about it and it makes sense. And then if you fold in the really hard stops, Mike, we're good. Our docs like coming in and seeing the patient, or the phone's been working really well all this time. We'll just keep using that for now. And maybe like my favorites were the really honest folks who said, our doctors just don't like it. Well, you know what? You have to have a bit of a thick skin, at least before COVID, before, you know, to be in telehealth. No matter what lens you're looking through, it's a different world now. And Don, to answer your question more directly, it's keep it simple for both organizations. If this sounds straightforward and as an obvious no-brainer, don't be amazed. Simple is harder than it sounds. I'll give you an example. A great place to start, if possible, use tools that already exist within your organization. If you can easily extend the use of these tools into other organizations, do it. If not, use tools that aren't relying on any one particular organization's technical infrastructure. Use something that can run alongside it and be deployed with minimal, and I have to highlight, minimal effort, like Zoom and iPads with cellular, for instance. You'll need to make sure of other really simple things that, if not addressed, will throw you back days and if not weeks. Like, make sure the location you're working with has reliable internet and that your interaction won't be hampered by a setting or using a guest network that doesn't allow a video or cuts off after a certain amount of usage. Try as much as you can to decrease the clicks and steps for you and that long-term care organization, but especially for that LTC, and I'll get into why a little bit later. Here's another one. Identify a key IT contact or liaison. Another one is clearly identify where and when and who will be facilitating the visit on both sides. And what sometimes is lost or diluted when implementing quickly, and I've learned this the hard way, is identifying an accountable contact, someone that's really accountable to make it work, someone that's on the hook to make sure that things are working and the handshakes are happening for each organization. And last but not least, you know, remember that the best workflows take both organizations into account. Yes, standardize where you can, especially if you're providing services to many organizations or plan to. But that really means that you've really thought through what works for you and those organizations. Next slide, please.
Just as you go on, just
Sure.
I had a question about making sure that you know who's facilitating the visit on both sides. since we've got a mostly emergency medicine audience on the line, so who is mostly doing, in the places that you're working with, who's mostly doing that in the emergency department? Is it the emerg physician who's on shift? Is it a designated other emerg physician? Is it somebody else within the organization?
Well, it's mostly of the first two that you mentioned. It could be somebody that's on shift and, you know, that they're covering the ED as well as maybe urgent care centers, or it could be somebody even remote that isn't in the ED but is covering all remote sites, including the PALTCs or urgent care remotely.
So I know that taking these kinds of calls from anywhere, long-term care, has often been seen as an annoyance, in part because it was really outside our scope of work and therefore not being remunerated. So I think some of that might change, where we just come to see that we are providing emergency care to somebody in a long-term care home who just isn't yet or doesn't need to be in our emergency department. So I'll let you go on with this slide.
Sure. The other make or break principle is commitment. Isn't that like the story with with everything? Commitment. These organizations have already been feeling the changes and pressures of taking care of an increasingly older and more clinically complex population. Now with COVID, the pressures have just increased. The staff that takes care of these populations have extremely hard jobs, and they already had a lot to do. For all the ED docs and practitioners out there, imagine any of the nurses that you work with now and dropping them into an LTC. Now, instead of having 4 patients, they have anywhere between 30 and 60. And they're responsible for things like trachs, wound care, TPN, JPs, passing out meds. By the way, passing out meds twice a shift. IVs, IV meds, sugars, insulin, new orders, and the list goes on. Incident reports, documentation, and even things as like that could just suck up time, like arranging transportation, testing, scheduling appointments. And last but not least, if you add in that there are more patients with psychiatric issues, the challenges become even greater. Another very important reason your commitment is absolutely needed is that these organizations have historically had a very high turnover rate. I don't know if some of you will be surprised, but their turnover rate is somewhere between 30 and 50%, and that includes administration. So the administrator that you were talking to today that's helping you set up your program might not be there in 2-3 months. So how you set things up and how simply you do that with the organization is vital. I say all of this to emphasize that these are precisely the kinds of organizations that your help is needed at. And that when you initially work with these organizations, it won't be perfect, even when you've checked all the boxes for communication, education, and training. All these will need to be on like a rinse and repeat cycle, and that has to be okay. In the end, your commitment means being patient, developing the relationship, and key here is building a new revenue stream and ultimately helping make healthcare better for the population and the people that support them. Next slide, please.
Mike, just an interesting comment in the chat box from Susan Bauer, who sounds like she probably works in long-term care, which relates to your comment about personnel. I would imagine long-term care facilities would need to have an increase in nursing and care staff to help operationalize the care rendered to the telehealth provider. Many long-term care facilities are understaffed or have limited training to handle complex orders, etc. Has this challenge been discussed? Do you think that's a real challenge?
I think that's a real challenge. She's right on. The thing that we've learned with these organizations is, yes, that it may take time, and nurses will be used more to their complete skill set when they're working with EDs, especially if you're treating the patient at site and you're avoiding the use of the ED at transport and hospitalization. Typically, these are things that are good to discuss with administration, and organizations that we've talked to that have implemented and used this and have matured with it feel that the nursing morale has actually increased, that their skill sets have increased, and that overall it's better because in many cases, you might, if I'm a nurse at one of these organizations and I reach out to my covering attending or provider, sometimes it takes, over an hour and maybe even more depending on what time of day or if it's a weekend or a holiday. Well, with the telehealth implementation, depending upon the relationship you have with the ED, you could have somebody on the horn or beam them in within 15 minutes. Now, if I'm a floor nurse or an LTC nurse and I know that I'm going from an hour to 15 minutes, I'll take that in a second. And yes, it might mean some more work for me, but at least I know I'm going to be getting some help and the right direction for that patient at that moment.
Don, this is Kevin. Just to add to that thought real quick. I think that that's a great question that came up about increasing the capacity of skilled nursing facilities. And the reality is that the skilled nursing facilities of tomorrow are going to be like the hospital floor beds of yesterday. The complexity of patients going to skilled nursing facilities is only increasing. There are places, as we know from prior webinars, that have COVID hot skilled nursing facilities. There are places that are using, as Jeffrey could explain to us, the 3-day waiver to send patients straight from the ED to the skilled nursing facility. So this is part of a trend to increase the utilization of skilled nursing facilities as sort of a hospital light. But that trend isn't going to happen overnight. And in the short term, it's to be aware that if you're doing this telehealth program, it might be to keep more patients at the SNFs. And if the staff there feels completely overwhelmed, they need to feel supported. Otherwise, you're shooting yourself in the foot. Final point, if I can, because I've done a lot of work in this space. Everything that Mike is talking about and is incredibly expert at starts with, these days, every other week, coffee and donuts with the skilled nursing facility leaders. I used to say quarterly. You got to increase the tempo now. You got to develop a relationship with your skilled nursing facilities. Every ER doc or leadership should know, which are the 5 ones that send us most of the patients that come from SNFs. And I should know the name of who runs that place, because you're not going to solve everything Friday at 10 o'clock at night. I know that. But if you're having a cadence and a trust-built relationship, that it's in that trust relationship that you can embed these telehealth programs to really improve the flow of patients. So give it time to evolve. And in the meantime, buy some donuts and coffee. At least have virtual donuts and coffee.
Kevin, great point. Appreciate you adding that. I mean, really highlighting the relationship aspect is key and vital, and will help you maintain that commitment. Real quick, Don, I just want to let folks know that West Health's created free downloadable resources for COVID and other senior-focused telehealth services. This information is especially helpful for administrators, among the listeners who want to learn more about the communities and telehealth best practices in general. And thank you, Don. I'm going to pass the baton back over to you and team.
Good. Thanks a lot, Mike. So the message seems to be as pragmatic as possible and make whatever you've got work, which is sort of what emergency physicians are good at. Now we're going to move to the diametrically opposite side of the country, from San Diego to New Hampshire. Kevin Curtis, I'm told that your place, Dartmouth Tele-Emergency, is the exemplar system for the country, the most mature and sophisticated, best developed system in the nation. That's taking the words out of somebody else's mouth, somebody else who's on the call. So it sounds like it's a good place for us to all learn quite a lot about. Can you tell us about your system and what makes it work so well? Kevin, you're on mute. Don't be shy.
Thanks, Don. And clearly it was worth the money that I paid to that person for those comments, so I appreciate those. So our emergency medicine telehealth service at Dartmouth is a hub and spoke model that involves live interactive audiovisual. So I'll give a little quick context before I describe it more. So as you said, Dartmouth Hitchcock is in New Hampshire, within northern New England. And that's an area where the majority of people live rurally, and about 50% of the hospitals are critical access hospitals. And each northern New England state, meaning as you see on the map here, Vermont, New Hampshire, and Maine, have one academic medical center. And as you'd expect, that's where the majority of specialists work. In addition, as is typical of many rural areas in the country, many people are well over 2 hours away from a referral center in the summer, and it may be impossible for them to get there in the winter. And then along those lines, also, as we all know, rural hospitals are struggling in the country. Many are closing, and a whole bunch more are at risk for closing. So all of that together resulted in us forming a Center for Telehealth in 2012, really with the goal of how do we bring care, and especially specialty care, to people in the region independent of where they live, and how do we do that in a way that will support our smaller rural hospitals with not only that specialty care, but allowing more patients to get more of their care close to home in their local communities and their hospitals. So if you look on the banner on the bottom of the slide here, among our 8 telehealth services that we have at Dartmouth, 2 of our earliest ones were tele-emergency and tele-ICU. And our thinking was that if we could get involved early on with the care of some of the most critically ill or injured, then we could really have an impact on their ultimate trajectory and their outcome. And the other thing is, early on, we've collaborated closely with Avera eCare in South Dakota, and they convinced us of a couple things. One is, if you want to be integrally involved in the care of critically ill patients and bad traumas and sick kids, you need to be a couple things. One is you need to be immediately available. You need to have universally reliable platforms. You need to have high fidelity equipment, and really with hub-based camera control, and you need to have a bird's eye view of the room. So we took that information and we built hubs for both tele-emergency and for tele-ICU in our medical center. So on the tele-emergency side, and if you go to the next slide, please. There are 4 identical stations for tele-emergency, and they include a microphone and camera, and that camera, as I say, is manipulable from the center itself. And they also include a doc and nurse available 24/7, 365, and all they are doing is tele-emergency at that time. So even though all of us also work at the bedside, those shifts are separate. If you go to the next slide, please. On the spoke side, so at the 11 hospitals that participate in tele-emergency in northern New England, each of them has 2 rooms, quote, hardwired for tele-emergency. And that typically is their trauma room and their recess room, but ultimately it's up to them. And in those rooms, as you can see in the red circles, if people can make those out, there's a monitor and a camera up in the corner. There's a microphone hanging down, kind of out of the way, and there's a button on the wall. And that button, anyone on the local team is empowered to hit that button anytime they want if they're looking for any kind of help from the hub. When they hit that button, it rings directly into the hub. We identify what hospital and what room they're in, and from that point forward, it's live interactive audiovisual. And we really think of ourselves as a doc and a nurse walking into the room, just like if we were physically there, and saying, we're available, how can we help? To give a little idea of what that help may look like, it can be the local site wants both the doc and the nurse to start a case or manage a case initially because they just got a surge and they're swamped and they're busy with other care. It can be a second set of eyes or a collaboration on a difficult case or a tricky resuscitation. It very frequently, the request is for nursing only involvement, that the local team says, we got it covered, but we got a code and we'd love the nurse to do all our documentation for us and tell us, when is it time for the next epi? When is it time for someone else to do compressions? Let us know if there's been a change on the monitor, or someone called something out to be done, and actually you can see from your bird's eye view that it really hasn't happened yet. Can you give us a reminder? Just a couple other things. Sometimes it's ongoing care of a critically ill or injured patient so that the provider can get on to see the other 5 patients that have come in since this one started. It can be procedural assistance, it can be eyes on by a specialist, and it can also be transfer coordination and acceptance by the referral center as well as transport. Certainly, at least pre-pandemic in our region and at our hospital, referral centers like ours are at capacity every day. And unfortunately, it can be 45 minutes to a no to get accepted or to try to get accepted. So we'll take that work off their plate, find the place, get acceptance, even if it's not us. So those are just some of the examples. Most frequently, our most frequent calls are trauma, cardiac, respiratory distress, altered mental status, and we see a fair amount of kids. About 40% of the people that we're involved with are 65 years of age or older. And just a little comment that won't surprise anybody probably on this call, but older folks are at least as open and engaged to our telehealth interaction in teleemergency as younger people, and often more so. They really just accept it into it as a part of their care and are very open to it. So that was interesting, but not completely surprising to me.
Kevin, I was going to ask a question. Are there any particular learning points or challenges regarding caring for older people by telehealth? That's one that you don't notice, but are there others that you've had to teach your folks about?
I think actually the lessons learned overall apply equally to older folks and younger folks, meaning that one of the, maybe we'll talk in a minute about what we call website manner, but the pace and the clarity of your communication with both the bedside team and with the people you're interacting with, older or not, is even more important in a teleemergency coming on a monitor, not right there as bedside, as even having been at the bedside for 20+ years. So I'd say that is certainly something that we pay attention to all the time, but is even more important. One situation that comes up all the time that I think, again, is good practice overall, but I found it to be extra helpful when the family members of the patient are older, is one of the things that happens frequently. Think about your own ED, is there's a bunch of bustle when the person arrives, and then a whole bunch of things happen, and they're whisked off to CAT scan for some flavor CAT scan, and left behind is the family to wonder what just happened and where did they go and what happens next. And particularly when the family left behind is a little bit older, we take that time on teleemergency to talk with the family, explain what is being done, explain with the why there's a CAT scan, what the next steps will be. And that is really reassuring and not a feature of teleemergency that I prioritized when I was first starting to do it.
Certainly sounds like an awesome system that you've developed there. So what are some of the other learning points that you've got for us?
Well, I think one we've heard a couple times already, and I couldn't emphasize more, is that a successful teleemergency program, or our success, is based very strongly on relationship building, much more than medicine. I'm sure there's a whole bunch of people on the call that can practice outstanding emergency medicine. But what you're asking the local team to do in teleemergency is to say, let's take your most stressful, difficult case of the day, and could you bring on 2 people from our hub that you've met a couple times on the camera and maybe once in person? And could you involve us to watch what you do? Now, that's not how we frame it, but really that's the ask. So we spend months prior to going live, the equivalent of what Kevin was just saying about, coffee and donuts. We go to the sites, we sit down with the providers, we sit down with the nurses, we sit down with the staff, and we just talk about what we do and how can we be valuable. And I'll just say that one of the very important things about the relationship in teleemergency, particularly where a lot of our hospitals are smaller and critical access hospitals, is that I completely believe, and our team believes, that critical access hospital emergency medicine is unbelievably impressive. They're seeing the same patients as I'm seeing with many fewer resources. So it is not a place for ivory tower snobbery, or whatever the right term for that is. So first we believe it, and then we spend a lot of time building the relationship. And then once the service goes live, at a minimum, once a day, the local team, quote, hits the button, and we call it checking the technology. And what it really is, a chat about the weather and to say hi and say, who's your team today? Here's our team, how's it going? How did the Little League playoffs end up? I remember we talked about that last week. So it's all about, that's probably the most important thing. I think others, just one other in addition to the fact that how impressive critical access emergency medicine is very recently in the, in this COVID world, as COVID continues to come to your rural or even your non-rural community, this or a scaled down version of it, and we could talk about that, is a nice method to spread your emergency medicine resources, deliver care remotely, and again, obviously limit exposure, preserve PPE, and then really support your local rural hospitals that, we're all challenged financially right now. It's certainly not the most important thing or even the top 5, but the more that we can support hospitals and communities to get through this, teleemergency can offer that.
Thanks. So just as you're wrapping up, I'm reminded of Mike Kurlian's request that from everybody that they want this to happen tomorrow. Hard to build your system in 2 or 3 days or by the end of this particular crisis. What would you recommend for somebody who wanted to go low tech and fast?
Yeah, so this isn't a sales pitch, but I'll first just say if fast is 3 weeks, we've moved down our implementation, as I know that Avera has as well, from something like 75 to 90 days to 20. So that would be one option, is to participate with someone who offers it. But really other options that you're asking. So the first thing I would say is everything we do in telehealth is identify the gap or need that you have, and then see if telehealth can respond to it, and then wrap some technology about it. So only to say that identify if you're trying to do MSEs or you're trying to take care of very sick people with less people in the room, and then identify, as you said, your time frame and budget. So in addition to our ongoing system, we have put the hardware alone in 8 of our negative pressure rooms and connected that room hardware to tablets and to a telehealth cart in our own ED. And we're using that from the full spectrum of emergency medicine, from, again, MSEs to codes to intubations to resuscitations to consultants from home to nurse to rounds. And some of that not only is the hardware, but we're doing it similar tablet to telehealth cart and tablet to tablet. You're obviously lose a little fidelity, but it is still clearly value added. And you can do that in the region, not just in your own ED.
Can you scale that down one technology step further to just a telephone? How much of this could be reproduced with telephones?
Yeah, so I think that's an area that most people can quickly get their mind around. So meaning that we've had, we call our patients, we check in with them or give them follow-up. I would say not much of what we do on an average full tele-emergency shift would easily translate to phone because that bird's eye live interactive, but within your own emergency department, again, well-defined use, to extend it, for example, to on our outpatient virtual visit world, which was our least probably mature by volume service. Prior to the pandemic, we were doing 10 visits, telehealth visits a day, and now we're doing 2,100 a day. But 2/3 of those, even at a mature program like ours, are by telephone, and that's working successfully for one tier down in urgency.
Good, thanks, Kevin. So we are coming around to the top of the hour. It always seems like there's more material to cover than one can in 60 minutes. Lots and lots of stuff happening in the chat box. Eula, do you have any particular question or topic you'd like to send out to our panelists? If you're talking, you're on mute. You are.
Sorry, thank you. Thanks again to the panelists. We've had some really great chat discussions. So again, encourage everybody to read the chat for some thoughtful ideas. Some questions specifically for the panelists. Risks, benefits of telehealth, and how are you measuring the efficiency and impact of telehealth, or how will you be measuring if there were one thing you had to measure to say that this was working well or not, what would it be?
Kevin, go ahead.
Sure, I'll take a crack at it. So one thing I'll just say, it's an outstanding question, and I think something that we need to pay much more attention to, particularly if we want to take advantage of extending the CMS guide or payment models that have been put in place. On the flip side, I'll just say it's probably need to refine the question a little more, or I end up refining it a little more, because it's a little like, because telemedicine is all of medicine, which models of telehealth are you referring to? But for all of, meaning that, you know, telestroke is a different model maybe than tele-ICU, than outpatient virtual visits, than urgent care. But for all of them, I'm a kind of a quadruple aim kind of guy. And so for all our services, we make an effort to measure what are the impacts on health or outcomes, what are the impacts on cost, what is the patient and family experience, and what is the provider experience. And that's formed, we've measured those, and those formed a really nice framework for each of our different services.
Yeah, I'd like to add, you know, agree with every one of those great points that Kevin Curtis just mentioned. You know, I think there's some creative ways of looking at downstream utilization as well. You know, once you start using these services, and there are so many different types of telehealth services, one of the things that we can look at is just to see its impact on the outcomes, like Kevin mentioned, and how they impact our downstream utilization, which hasn't been studied enough.
A world of unintended and intended consequences. So I would urge everybody, you've probably been keeping an eye on them, to check out the chat box. There were all kinds of other interesting questions from Chris Carpenter about research questions, because I think there's a lot of things that we don't know about this brand new field, and that will be particularly relevant for geriatric care as well. But we are coming to our conclusion. So I would like to thank all of our panelists. It was a great walk through an overview, funding issues, and two really practical, real life implementation issues and what you can learn from them. Next slide, please. I'm sorry, I should mention that all of this, of course, will be available on our website as of later tomorrow, including the article that summarizes all of these points. Now, next slide, please. Finally, I do want to thank our funders, John A. Hartford Foundation and West Health Institute. Many of your folks were represented on the webinar today, including Mike Kurlian from West Health. And I just remind everybody on the webinar, we will be doing this again in 3 weeks. The topic then will be palliative care for older, issues in palliative care for older emergency department patients. in this time of COVID, but as always, all the time. So please join us again 3 weeks from same time on June 1st. And with that, I'll say a final thank you to everyone on the call, and see you later. Stay safe. Bye-bye.
Thank you. You as well.
Thank you.
Thanks, everybody.